This is Advanced Professional Practice, Unit 6, Part 4. Last week we talked about field pronouncement and termination resuscitation, and this week we'll talk about care for the family of the decedent. This is largely adopted from a presentation that Greg Soto put together from the Niagara-based hospital, now the CPR, I guess it is. Or maybe it's not CPR, it's anyway the Hamilton-based hospital area. So, what do we know about caring for the family when it comes to cardiac arrest in the out-of-hospital setting? Well, there's quite a few studies have been done, and to start with, from a clinical standpoint, there's new research that suggests that CPR should be done for a minimum 35 minutes on the scene, and that's based on a really large cohort of 17,000 patients. So they should be given the benefit of at least 35 minutes of resuscitation. We know from two pretty big studies and a few others that families are quite ready to accept a death pronouncement from paramedics in the field, and that they feel that the grief support that they receive was more than adequate. And yes, Chris, the study involved ALS care, that 35-minute resuscitation. So DBM and death notifications, family members are accepting a termination of out-of-hospital cardiac arrest in the field, and a few studies have shown pretty significant satisfaction expressed in terms of emotional support, and there are other reasons that families prefer a death pronouncement in the home as opposed to in the hospital, and I'll touch on that just shortly. So many stated that they already knew that the patient was dead when they called 911. And when I say dead, I don't mean code 5. I mean just they knew, they understood, they recognized the death, and expressed that they were more comfortable grieving at home around family and loved ones. They felt closer to the deceased that way. They knew more about what was happening compared to families who were surveyed who experienced a death pronouncement in hospital, and some expressed that the deceased would have wanted to die at home. And conversely, family members of transported patients expressed less positive interactions with EMS and ED staff, largely because when we transport, we tend to communicate less with family. And they felt anxiety about rushing to the emergency department. They felt lonely sitting in the waiting room waiting for information. They felt guilty in going to the hospital when the patient was often declared very quickly, or they felt futility rather, when the patient was declared very quickly. And on the grief scales, there was a trend of more positive emotional adjustment for families of non-transported patients versus families of transported patients. And it mattered less to survivors who gave the death notification. What was more important was the manner in which it was given. So the studies have shown that paramedics are, capable and competent at giving death notification, but there's a certain knack to it, a certain skill to it, and most, if not all of you, have done tours before, so you've had that experience. In the home, families expressed that they felt less rushed. There was more personal communication, appeared to produce a more positive perception by the bereaved, and the ability for the family to be present during resuscitation facilitated their adjustment to the death and the grief process in those cases where the families were allowed to stay. Personally, I've never invited the family in to watch a resuscitation, but if they happen to be standing there, I don't usher them out. But you've got to assign someone to stand with them to watch over them in case they, have a syncopal episode or something. Keep an eye on them. In hospital, I've seen that too, where they've been involved or been present for the resuscitation. So, pretty consistently, the conclusions found that paramedics were able to inform survivors of the death, provided answers to questions regarding treatments and protocol appropriately, provided care not only to the family but to survivors, including the grief support. So, Chris, when you say it's hard for first responders, but uh, from what you've heard, I'm not sure what you mean. Feel free to use your mic if you like. Might be easier.
Does it actually work?
Yep. Yep. Works fine.
So harder for the responders because there's a lot of like black humor and stuff that goes on usually during resuscitations because it's a really high stress time. So it's harder for responders to kind of cope with a lot of the things that go on during resuscitations. And then usually I find, at least with out of hospital, because we don't have as many hands as in hospital, um, the resuscitation is usually not very fluid, and there's usually a lot of things that kind of go wrong. I'm trying to like rush around, and having family there sometimes can get really complicated because you don't always have somebody to actually sit with family and explain while we're going through that. Because sometimes it can be really traumatizing for the family when you're trying to get a tube down their throat and intubate the patient, and it looks really bad. You're constantly suctioning or something. And for us, it's a normal procedure, but with family not having somebody to explain that, it's a little bit harder. So in hospital, I've seen like they have like sometimes the chaplain will be there, or they'll have somebody who's actually assigned to deal with the family situations. But in home, it's a lot harder.
Yeah, and I think that's what I was trying to say too. Is what it's key. It's critically important to assign someone, a paramedic, specifically a paramedic, to the family member or members if they're standing around watching resuscitation. And sometimes the ACP running the call, if you're the one standing up, standing and just barking out orders, that might work if you've got enough hands on deck. But we're caught in a bit of a dilemma because if there wasn't someone standing there talking to the family, I would be reluctant to usher them out. I might say to them, do you want to stay, or would you like me to come out later and explain what's happened? Because sometimes they find themselves in the room, and perhaps they don't even want to be there, but they just don't know what to do. They don't feel like they can budge. So somebody has to communicate with them in some way, shape or another. But you touched on the dark humor that happened. I have a real issue with this on cardiac arrest scenes. It didn't used to bother me, and frankly, I participated in the past, but I have like a zero tolerance for humor on a cardiac arrest scene. And one of the recent cardiac arrests I attended, there were two people there who, I won't say which service they were with, but they were making jokes, and the wife and the two young daughters were standing nearby, and I just about lost it. I said to those guys, stop right now. And it's just, one, horribly unprofessional, and two, that kind of incident is so intense for the families, for the survivors, and they're going to have an indelible memory of everything that was said and everything that happened on that scene, particularly the jokes. And they're going to think over in their mind, did they not take this seriously? Was it a foregone conclusion that my husband was going to be pronounced dead? And I find that really disturbing. Josh? Again, feel free to use your mic, Josh, if you've got one. Oh, wait a sec. Let me unblock some of these mics. Okay, go ahead.
No, sorry, I think I hit that in error.
Oh, okay, no worries. So, caring for the family. During the resuscitation, someone needs to step away to speak to the family. That's usually the lead paramedic, but it doesn't have to be. It should be someone who's the highest medical authority, but that doesn't have to be either. That's not a necessary requirement. But someone who feels comfortable speaking with the family, speaking to what's going on. And it's important to explain things to the family in a frank manner. and I'll use words like he stopped breathing and his heart has stopped beating. We're providing artificial respiration and circulation with CPR, and I'll say that fairly slowly because those are words that they will understand. I also give them a heads up about the prognosis, and I'll explain things that we put a tube in his airway, and it doesn't matter what kind of tube. I'm not going to use the terminology for the tube, whether it's a King LT or an endotracheal tube, and I'll explain that we've put in an intravenous line and we're giving medications and we're trying to get his heart beating again. But I'll tell them, if I'm not optimistic, I'll say I'm not hopeful that we're going to be able to get a pulse back, and I'll be frank, I'm not hopeful that he's going to survive. It doesn't look good right now. So I try to explain or convey the gravity of the situation with some candor and with some compassion simultaneously. And then post-pronouncement, again, important to be candid, but not callous and not clinical. And it's important to say things and give it time to sink in. I think the mistake some paramedics do is they talk, and when they don't hear anything back, they just keep talking and talking and talking. And that's not a good idea, because it just adds to the family's confusion. It's better just to express your sorrow for their loss and let them sit and process the whole thing. So compassion will help the family accept. I know when my dad died in 1984, he was in hospital, and back then, so he had a couple of MIs, and there was nothing they could do for MIs. They didn't have PCI back then. There was no angioplasty, didn't exist. The only thing they did was they gave patients nitro and morphine, and did repeat cardiograms and just hoped that they would survive or they'd die. And my dad got what I felt was substandard care. One night I was there, and he was having chest pain and nobody was coming, and I went to the nursing station, and the nurse said everyone's on break and I'm the only one here and I can't come. And I said, well, you need to call a physician because he's having chest pain and I'm giving him nitroglycerin. And she said, well, kind of gave me the whatever look. And so I was angry, and I was angry for several days while he was in the hospital. And then we got a call at 2 o'clock in the morning saying they moved him to the intensive care unit and we should probably come down and be there. So my mom and I went down, and I was seething. I was angry at the care he received. I went in to see him, and he didn't look all that great. And then I heard a code called, and my mom asked me if it was for my dad, and I said I think it probably is. And then the doctor came out, and she sat beside me, and she explained what happened to me and my mom, and she was so professional and compassionate and empathetic and did all the things I think a person should do after a pronouncement. She said what she had to say, she paused, she asked us if we had any questions, and when she left, all of that anger I felt, all of that resentment that had built up, all of that feeling of you people are incompetent and don't know how to look after people that had built up, was all completely and utterly washed away. It was a really incredible experience that stayed with me throughout my entire career. And I thought, if I'm going to do a pronouncement, this is how I'd want to convey the information. It was really, really impressive. So we want to show respect to the family, obviously, and the deceased, and the humor stuff that can happen after the call. There's no place for it on the call. Anyway, I couldn't tell you the name of the doctor. It was 1984. I was 3 months out of school. I knew really nothing. I don't remember the physician's name. I don't even know if she still works or she's retired. She might have been a great guest lecturer for sure. So sometimes patients will ask us, or family members will ask the same questions over and over again. Just feel free to answer the same question. Maybe phrase it a little differently. or just assume they didn't hear you, didn't process it the first time around, because a situation like this clearly is overwhelming, right? So when do police attend? I'm not telling you anything you don't already know here, but when a death is unexpected, where I work in an urban center, police are always there. It's a non-issue. Where you work, that may be the case as well, unless you're up north. Terry?
I want to go back to the last topic. I was wondering if anyone else does this. So once I had after it was a medical pronouncement, I had a police officer kind of sit the family down and do a little bit of a talk, and I kind of joined in, and I'll let them do it, or let the family know exactly what happened, and they really liked it actually. But I'm pretty hesitant to do it. I've never done it again because I wouldn't want to convey the wrong information to the family. I'm just curious. Have you ever done anything like that, or does anybody else have a similar experience?
Terry, you're saying like giving the information with the police?
Like no, like sitting the family down after and having sort of a discussion about what happened. Of what's our side of it.
Yeah, so I can't speak for the rest of the class, but I've done it dozens and dozens of times. And that's usually, more often it's me than the police, but I have sat down with police as well. Like, police are usually sitting down with a family member having discussion, and then after the pronouncement I'll come and sit with them and basically step in and explain what's happened and express my condolences. But
okay, yeah, we just usually give our condolences, and that's about it. I see Charles and Chris. Yeah, okay, that's something I would like to do.
Yeah.
So,
and you know what? As odd as it sounds, it's an immensely satisfying call to give the information to the family.
It is. Yeah.
I mean, I feel, after my experience with my dad, I feel like if I can convey that information in a similar way, I feel like I've helped the family to get some closure. But you do have to be careful what you say. Like, I won't say I'm so sorry. I'll say I'm so sorry for your loss, right? So they 3 hours later in their mind, they're thinking like, why is the paramedic sorry? Did he screw up or something? Because they will analyze everything, and everything that you say and do will become an indelible memory for them. So I'll tell you another quick story. My sister, who's a little older than me, her husband died a number of years ago. He's 42 years old. He was a healthy guy, but he had a prosthetic heart valve, and something went wrong, and he died and went into cardiac arrest in his sleep, and it woke her up early in the morning because she noticed his breathing was agonal. Well, that's not how she described it. And anyway, it was a horrible experience for her for a number of reasons. One, dispatch insisted that she get him onto the floor, and he was a guy about my size, and she's fairly petite, and she didn't have the strength to get him on the floor. The medics came, and she said the medics were nice and they were professional and everything, but they left a big mess behind. They left a dirty oropharyngeal airway on the floor that had blood on it. They left an oxygen mask on the floor. They left plastic and debris just everywhere. And she was ridden with guilt over not being able to get him on the floor, over not being able to do what she thought was adequate CPR and the rest of it. And for months, because she started sleeping on the sofa, she couldn't sleep in her own bed again. She sort of avoided the bedroom, and every once in a while she'd go back into the bedroom and she'd find another piece of garbage somewhere under the bed or on the floor, and she'd clean it. It would bring back that horrible memory. And as late as like a year later, she went into the room and she dusted under the bed and found an oxygen mask with the open packaging, and relive that whole horrible experience again. And so I'm really diligent about cleaning up the scene before I leave now for that reason. And especially things like blood. We had a guy not long ago. We had a little bit of trouble starting an IV on him, and there was some blood on the floor afterwards, and we didn't get the chance to clean it up. So I stopped, and we ended up transporting this guy because he remained in VF, and I spoke to the wife and explained that there's a little bit of blood on the floor. My apology, and I said it's nothing serious. We were just starting an intravenous line and spilt a little bit. but I really try to clean up so the family's not left with the sort of the battlefield of debris left behind that's going to give them flashbacks to that experience. So, when do police attend? So, when it's an unexpected death, obviously, or when it's expected but the family's just unable to cope with the situation. And we have some police teams, as you do, I'm sure, who deal with death and dying and are able to help the family get everything organized. Any suspected foul play. And if there's any suspected foul play, it's important. And our number one priority is resuscitation of the patient number one. Number two is to try to leave the scene as undisturbed as possible and preserve as much evidence as possible. So, and that's it, really, for that presentation. Any other questions or points people want to raise, experiences you want to share? No. Okay.